Good evening, and thank you everyone for coming. Hopefully some more will trickle in later. We actually had 150 registrants for tonight's event, and I know you all had a lot of options in what you spent your time this evening doing. So thank you for spending some time with us. Tonight we have the pleasure of two different kind of eyes looking at a disease state you guys probably see and encounter on a very, very frequent basis. And the reason of bringing the allergist specialty with the optometric specialty into one room is feedback we've gathered by talking to both specialists in advisory board type settings. And it's great to get different perspectives and approaches in disease management, therapeutic options of treatment, and kind of the role that each specialty can play, and primarily in this room, the role that optometrists can play in managing the disease. So this evening, we have Dr. Bill Storms. He's clinical professor from the University of Colorado Health Science, the NIH asthma panel member. He's the U.S. Olympic Sports Medicine Advisory Committee, as well in current practice of allergy and immunology and clinical research in Colorado Springs, Colorado. He just flew in earlier today to participate. In addition, we have Dr. Paul Karpecki. He's Corneal Services and Ocular Surface Disease Research Director at the Koffler Vision Group in Lexington, Kentucky. So they're going to discuss epidemiology, disease state, therapeutic options, get into some clinical information around Bapiva and Alvex, and then we will open up the opportunity for you all to ask for their insights and feedback and answer any questions that you all may have. So thank you all for attending, and I'll turn it over now to Dr. Paul Karpecki.
Thanks, Adam. Thanks. Give me that remote. I think I'll use that. Thank you, Adam. Perfect. Well, first of all, I want to thank you as well for being here. I know in these evenings there's a lot of things you could be doing, a lot of events, a lot of alumni functions, so appreciate your presence. Also want to compliment Dr. Storms, the honor of getting to present along with him. A couple of people asked me what a dinner program I had tonight and whether it was Milton Hom and others, and everybody said the same thing about him. He said, man, he's one of the nicest guys, one of the best people besides his knowledge. So I got to meet him in about 10 minutes, and I'd have to say, even in that short time, they're 100% right. So I'm honored to get to be able to share the podium with him, and I think you're going to find this is interesting how you get the ocular perspective and the allergist perspective, and we learn a lot many times, or at least I tend to learn a lot when I hear other perspectives, and the allergist really looks at things surprisingly different. Even though there's a lot of overlap, there's a surprisingly different approach, and you may see that as we go through all of this. So I'm going to begin by really looking at ocular allergies, the epidemiology, how important this is to the profession. Now, it's tough sometimes to speak on allergy to colleagues in optometry because we're now the #1 eye care prescribers of allergy medications in the United States. So sometimes when you're #1 in a category, you kind of feel like you already know most of the stuff around it. But there's a lot of new developments and new things that have come along and new understanding, and hope to share some of that with you as well. So ocular allergies do affect many in the U.S. In fact, you know, the percentage of patients affected by some form of allergies is as high as 80% that as far as having symptoms. And that can range anywhere from mild seasonal allergies, of course, to quite severe, as in anaphylaxis. But these are the ones that report some sort of symptoms, most of it, of course, being the allergy components and rhinitis, itchy palate, etc. A lot of those patients will actually go to someone like Dr. Storms, less likely of ours. Having said that, of that population, if the U.S. population, 40% are affected by allergic conjunctivitis. That's a huge number. It's perhaps one of the most important areas for us to focus on as a practice. Even taking it further, you know that if both parents have allergies, there's over a 65% chance the child will have allergies. So the numbers just continue to keep improving. And if I keep increasing. And if I gave this presentation, let's say about 5 or 6 years ago, that number was typically around 30%. So why have we seen such an increase in this population? There's a number of theories that range from just climate effects to what's going on. But one of the leading theories is really even the hygiene theory. And I saw a comic, actually, that was mentioned this morning if you're in one of the talks, but I was looking through a newspaper and it had a little comic, and it was, I wish I could have cut it. I cut it out, but I wish I would have kept it. I don't know where it ended up. But it was very telling of the hygiene theory. It showed the mother and her son in the 1970s. And so you see this mom opening the door, looking outdoors and saying, hey, Billy, it's time for you to come in for your vitamin. And Billy's out there saying, oh, Mom, not now. I'm playing baseball. And he's out there with his baseball bat, and there's dust and there's stuff all around him. And then they said, okay, in the year 2013, they they had the same idea, but this time mom isn't yelling out the door in the outdoors. She's yelling up the stairs and saying, hey, Billy, it's time for you to take your Lipitor. And of course, Billy's up there and he's saying, not now, Mom, I'm playing baseball. And you can imagine he's on his Game Boy in his room. But it's very telling of what's happening. We're not getting as much exposure to allergens. We're seeing a significant increase in this disease. But seasonal and perennial allergies account for 95% of all the forms. Then there are the less noted but very severe forms like vernal, atopic keratoconjunctivitis, and even our GPC that we see in our contact lens wear. So we have to keep in mind all of those. GPC is somewhat increasing, and vernal is probably a little underdiagnosed, but as a whole, 95% are going to be related to seasonal and perennial. This stat really surprises me, though. More than 41 million bottles of OTC medications, only 4 million coming out of our office for branded prescriptions. Now, there's no way, if you look at those numbers, that even if you took 40% of the population here and 70% having allergies, that technically this is about $6 billion, $6.5 billion. If 40% of the population have allergies, then out of 41 million, we should have probably 20 million prescriptions for our Bepreves and other branded kind of medications, and yet that number is only 4. So what do most people do right now when they have allergic conjunctivitis? They use the Visines, the vasoconstrictors, the Nafcons, Vasicons. And although those may help temporarily, they really don't do much more than mask the condition and lead to, of course, a condition known as rebound hyperemia. And keep in mind, if you ever have a patient on Visine, don't suddenly stop it because they get really red eyes and wonder what's wrong with this doctor who made my eyes really red. You almost have to start them on something like an Alrex or a steroid for their allergies and then slowly take them off the Visine. But this also tells us we have a lot more educating to do for patients because these aren't the best medications for this condition. So if you look at the importance of professional care, we have to diagnose allergic conjunctivitis. We're going to go through that, even though we do a lot of that already in our condition. But more importantly, we have to differentiate it. Dry eye patients are really prone to having more allergies. And it makes sense. If you've got dry eyes and an allergen hits your eye, you don't have the tears to wash it away, so that extra contact time is going to lead to many more problems. But likewise, someone who uses an over-the-counter oral antihistamine like Claritin will often dry their eyes out and lead to dry eye symptoms. In fact, there was a study by Usler that showed that just 4 days of Claritin use, once a day, decreased tear volume by, does anybody know how much? 34% in 4 days. So really, it has great drying effects. So if someone... I tend to avoid the oral antihistamines, and we'll talk more about this in a person who shows up into my office. And the reason being, if their primary complaint was the non-ophthalmic symptoms like the rhinitis and the nasal congestion, the itchy palate, they would see someone like Dr. Storms. If their main complaint's their eyes, I'd really be hesitant to dry their eyes out by 34%. And that's one of the better, less drying forms of oral antihistamines. The other part that's difficult is kind of how do you differentiate all of these various diseases? And obviously blepharitis, you know, when a person comes in with itching, which we know to be the hallmark of allergic eye disease, the first question you might want to ask is, where's the itching? Because if the person says it's on the eyelids, what condition might that be? Probably blepharitis. And actually probably Demodex blepharitis if you want to get real specific. Patients with Demodex, where you get those kind of clear sleeves at the base of the lashes, their number one symptom is itchy, and then eventually they get matarosis or loss of lashes. If they say it's in the carbuncle area or it's on the canthal or even the limbal or on the eyeball itself, then typically it's going to be a form of ocular allergies. Other things that confuse it are preservative toxicity, and again, this can apply to many of the things like the Clear Eyes and Visines, things that have a lot of BAK in them and can actually compound the issues. And as I talked about, some systemic medications, most of them have significant drying effects as far as the antihistamines. This is also interesting that only 25% of all the medications used to treat ocular allergies are by prescription. So people are self-treating and unfortunately probably not getting the full effects of where the potential is. Now, we're all pretty good about this part here. We all know itching has to be usually a typical thing. If you have itching, it doesn't mean it's allergies. You could have blepharitis or other things, but it typically is. But without itching, it's probably not allergy. So itching has to be one component. Redness plays a significant role. Swelling, chemosis, tearing, watery discharge, burning, stinging, and foreign body sensation. And I think this is very important. I tend to prescribe in my clinic, and we'll go through this a little bit later, but if a person comes in where their symptoms are much worse, typically that's more of a histamine release and chymase and tryptase. And Dr. Storm's going to go over the pathophysiology. I think those patients do respond better to a combo agent like a Bepreve, an antihistamine mast cell stabilizer agent. But when they start to get where the signs like redness and swelling and those start to catch up, then that's more inflammatory. And I find those patients tend to respond much better to a steroid like an Allergy. So I make a lot of my decision based on, is it more symptoms, which I'll use a combination agent, or is it more signs, in which I prefer a steroid? And I'll go over that with you a little bit later.
Thank you, Paul. I think I'll stand up over here so I'm not looking over you. So we'll talk about the allergic response. And the allergic response is present in the eyes, some patients in the nose with allergic rhinitis, some people in the skin with hives, in the lungs with asthma, GI tract with a variety of problems. It's the same response, just different organ. So first you have to have a mast cell, and the mast cell has to be sensitized with IgE molecules. Then when the allergen comes into contact with the IgE, there are some immediate mediators that are released. These are already preformed, and those are heparin, tryptase, chymase, and histamine. Now, when you think about the drugs we have for different allergic conditions, we don't have anything for heparin, tryptase, or chymase. We do have something for histamine, antihistamines. These cause itching, redness, and chemosis, itching being the major symptom. Then there are some mediators that take a little while to form, and that includes platelet activating factor, prostaglandins, leukotrienes, cytokines. The only drug we have in this area is Singulair leukotriene receptor antagonist, or Accolate, the other brand. Then, with a little more time, these mediators end up causing a late phase reaction. They attract cells into the area, basophils, mast cells, and eosinophils, and they are full of all sorts of bad things. They secrete these mediators, which then amplify this response. So your acute phase, within an hour or so, you have itching, redness, chemosis, and then you go into this late phase, which is more of an inflammatory reaction. There's still a lot of itching, redness, chemosis, but it's magnified. And then there's a feedback loop that keeps everything worse. So for the early phase reaction, antihistamines, mast cell stabilizers. For the inflammation, need the steroid. So itch relief for allergic conjunctivitis, what are the treatment options? Obviously, patients have a broad range of symptoms. They could be mild to severe, they can be acute, they can be chronic. So you have to decide what medication you want to pick for that patient depending upon their symptoms. There are many treatment options, and as you'll see, most people have done a number of these before they come into your office. Allergen avoidance is a little difficult. If somebody could tell me how I can get my patients to avoid the allergens, I'd like to know about that right now, because how many of you would get rid of your cat, dog, ferret, rabbit, whatever you have in your house because you have allergic conjunctivitis? Nobody, right? And that's about the only thing you can avoid is an indoor allergen. But then we have prescription products, topical systemic antihistamines, mast cell stabilizers, non-steroidal anti-inflammatories, dual-acting antihistamine mast cell stabilizers, and corticosteroids. So as we've mentioned, ocular itch is the main symptom, and the things that can bring this on include pollens on the left side. Tree season is in the spring, grass season is in the late spring, early summer. Weed season is in the late summer, fall until the frost. And these seasons overlap. Most people are allergic to more than one pollen, so they've got more than one season. They usually come in and they say, well, I have trouble when the seasons change. Winter to spring, summer to fall. Well, that's tree season in the spring, weed season in the fall. But then when you get into it, they really have milder symptoms all year round caused by things like dust mites, molds, pet dander. It's unusual to have people who are just allergic to one allergen. So what they realize is the severe symptoms only, and when you start treating them, they come back and say, well, yeah, that drop you gave me really helped, and by the way, I'm going to take that in the winter because I still have some of that trouble. So I'm going to talk about Bepreve. Here's the indication. It's a histamine H1 receptor antagonist indicated for the treatment of itching associated with the signs and symptoms of allergic conjunctivitis. Dosage, 1 drop of Bepreve into the affected eye twice a day. Pediatric use, safety, and efficacy have not been established in patients under 2 years of age. Important risk information. It's contraindicated in patients with a history of hypersensitivity reactions to BEPO or any ingredients. It's for topical use only. Don't touch the dropper tip to any other surface except drop it in the eye. Remove contact lenses prior to installation. Most common adverse reaction, I'll get to this in a minute, but just the summary, about 25% of patients have a mild taste following installation. Other adverse reaction occurring in 2 to 5% of patients were eye irritation, headache, and nasopharyngitis. So this is the first line option that's been shown to have rapid resolution of ocular itch associated with allergic conjunctivitis. I'll talk about the preclinical and clinical data, and then the efficacy, safety, and the comfort. First is the mechanism of action. As you know, it's both an antihistamine and mast cell stabilizer. It's a very highly selective H1 receptor antagonist. It inhibits eosinophil migration and activation. And interestingly, it has no significant binding affinity for the other receptors that are associated with either sedation or dry eye, serotonin receptors, adrenergic, muscarinic, and benzodiazepine. So it doesn't have the side effects that are associated with many other eye drops. And it prevents the release of histamine from the mast cells, so therefore it inhibits leukotriene, platelet activating factor, and IL-5 production. So it has the dual antihistamine mast cell stabilizing activity, and it's free of these side effects. Here's a typical study that was done, the conjunctival allergen challenge. I know you're all familiar with the CAC trials. In this situation, the patient comes in, they have to have a positive skin test to a certain allergen, and then a CAC response where they have a certain amount of itching after the allergen is put in the eye. There were 2 studies, Study A and Study B. Patients received Bepreve or vehicle, and the efficacy endpoints were taken at 15 minutes, 8 hours, or 16 hours after installation. The patients assessed their ocular itching, and the investigators assessed the redness. Obviously, the patients can't assess their own redness. And then the safety was evaluated by adverse events, visual acuity, slit lamp, IOP, and fundoscopy. So here's the first bit of data. This is looking at patients who have a CAC grade of 3 or greater, so that's quite high because the scale only goes to 4. So these are people with very significant ocular itching and showing ragweed pollen and grass pollen. And you'll see the improvement within 15 minutes. 77% and 88% had significant decrease compared to placebo of those patients with the more severe itching. So it shows that it works very well in severe itching. Here's the ocular itch scale I mentioned going from 0 to 4. This looks at complete relief of severe itch. So here again you have the patients with CAC reactions of grade 3 or greater, and they're looking at 100% improvement in their itch. So their itch score goes from 3 to 0, or 3.5 or 4. And you see that 68% of Bepreve patients went from 3 or greater to 0 on their ocular itch score, whereas almost nobody with placebo did that. Looking at another way to look at it, this is a 1-unit reduction or improvement in itching. So this takes all the patients, no matter what their itch score was, and what percent had 1 unit or greater itching within 15 minutes compared to placebo. And you see that 95% of the bepreved patients versus 47% of placebo had improvement. This was within 15 minutes. Then if you look at 8 hours, same data, greater than or equal to 1 unit of improvement, still 90% of the bepreved patients had that improvement. Let's go back to the previous slide. So 15 minutes, 95% had improvement of 1 grade or better. At 8 hours, 90%, 1 grade or better. So it shows that not only is the product working in all comers, it works in the severe patients, and it continues for a long period of time. This is a safety trial, so in this case, we had over 800 patients, and they had either bepreve or vehicle, 1 drop twice a day for 6 weeks, multiple safety assessments, visual acuity, slit lamp, physical exams, IOP, dilated, microscopy, and then the ocular comfort score. And this was a patient self-evaluated score looking at the immediate and the 5-minute post-installation comfort and adverse events. And basically, the top part of this is the raw numbers, and so you have to look at the total in each group to see what the percentages would be, and it's a little confusing. We just go down to adverse events. I mentioned that there was a mild taste that was noticed by some patients. You know, I've used the product myself, and I saw the data before I put the drops in my eyes, and I sort of convinced myself maybe I tasted something, but if I did, it was pretty minimal. But there was a taste sensation. Eye irritation, no statistical difference here. Headache, no statistical difference. Other issues, no statistical difference. So then we go to the comfort score, and patients, as I mentioned, gave the investigator their thoughts on the comfort. So there were 6,400 ocular comfort scores. 92% of the patients indicated no discomfort from the installation of bepreve. Obviously, that's really important because if you give somebody an eye drop that stings, they're going to think that you don't know what you're doing. And there were no differences in comfort between bepreve and placebo after either 1 or 3 weeks of dosing. So to summarize the bepreve data, this is a dual-acting antihistamine and mast cell stabilizer, very selective for the H1 receptor, and along those lines, it does not have the side effects that would be associated with other receptor activity. It has rapid and durable relief of ocular itching, and as I mentioned, it has efficacy against a wide range of itch severity due to a broad spectrum of allergens. I showed you the ragweed and the grass. Other allergens were studied also. It is comfortable on instillation and a very low incidence of adverse events. Again, I need to mention it's contraindicated in patients with a history of hypersensitivity to BEPO or any of the ingredients. And the patient copay assistance will be discussed by Adam.
So in all the advisory settings, and we reach out to practitioners across all different specialties, particularly for allergy, and ask them what really drives their prescription decision. In the allergy space, the first 2 answers are always managed care and cost. It's a very clinically crowded space. There's a lot of parity between the available options in prescription treatment. So we wanted to create a program to make it as easy as possible for a practitioner to know that patient will receive savings without you really needing to do any legwork. In practices I visit, there are so many coupons for everything from artificial tears to nutraceuticals to Restasis to allergy drugs to everything. There's just tons and tons and tons of coupons. So as a marketer, we have to hope, 1, you get the coupons, 2, you remember to give them out to a patient, and 3, the patient remembers to bring it to the pharmacy. So what we did was create an automatic program. It was highly successful with another brand I manage in Zirgan, so we wanted to roll that over to the allergy space with Bepreave. So it's an automatic rebate program for patients that have commercial insurance that go to a participating pharmacy, which is approximately 90% of pharmacies in the United States. That patient will receive a benefit of up to $50 off their Bepreave prescription without the patient needing to do anything or the pharmacist needing to do anything outside of what they normally do to adjudicate a script in their system. The coupons that we have, it's a 4-page brochure, and this is an image of the inside of them, talks about the 2 ways that there are to save. The first discusses the automatic rebate program, gives a table listing of all the participating pharmacies, as well as a website that you can put in a radius from your office or a zip code, and it'll tell you or the patient all the participating pharmacies within that set location. And on the other side is your typical point of sale coupon. And the purpose of this is for 2 patient types: true cash pay patients, where the automatic program doesn't work because the script needs to bounce off of a third payer in order to be adjudicated and recognized that they receive benefit, or for patients that go to a very small mom and pop type pharmacy that isn't a part of this what's called e-voucher program. And that's just a typical perforated coupon patient brings to the pharmacist. Sales representatives can provide this. I will provide some business cards as well at the end of the program. So if you don't have frequent sales rep coverage and you do want to get your hands on some of these coupons, please feel free to email me and I will FedEx them out directly to you in your office. So thank you. I'm going to turn it over now to Dr. Karpecki to talk a little bit about the late phase.
Great, thank you.
Yep.
Wonderful. I'll take some of those coupons. If we go through a little bit, that was a great presentation, understanding kind of the pathophysiology, and it kind of, and then right into Bepreave. If you look back to some of that, the early stages were more of the histamine release, and as he said, that's where your antihistamine combination agents like Bepreave do come in. The later phase is what we're going to cover now, where you saw the platelet activating factors and your leukotrienes and your cytokines and et cetera. So we're going to kind of look at how we differentiate those and how to manage this in light of steroid use. And allergists don't tend to use a lot of steroid drops in eyes simply because some have slit lamps and tonometers, very few do though as a whole. And so it tends to be much more in our world where the steroids are more commonly written because of the monitoring capabilities, et cetera. So we have to kind of understand where that all fits into. The allergic response is biphasic, meaning that some people might look at when to use a steroid versus when to use an antihistamine by the amount of time that's passed, and meaning if a patient's had allergies for more than 24 hours, there's probably some inflammation, even sooner, at 12 hours in some cases. Others say, no, I base it on signs and symptoms we talked about earlier. But there is definitely 2 different phases, and it's triggered through the release of histamine. So it does begin there when the mast cell degranulates, and then these antigens bind to the IgEs, as he has described at exosomes very well. There's cross-linking of those, and that's what then opens up the mast cell. And they release all of these mediators. Histamine, eosinophilic chemotactic factors are probably the 2 most prominent. And that leads, of course, to all of what we're used to seeing, the itching, the chemosis, the vasodilation, and redness. Histamine release is responsible, though, for that classic symptoms that patients describe when they come in. Significant itching, sometimes you'll see that edema of the eyelid, and even some chemosis. But in the late phase, it's really these leukotrienes and prostaglandins. And what drugs are most effective against these particular mediators? Obviously steroids. It makes more sense when you're dealing with prostaglandins because the steroids work at the level of arachidonic acid pathway level. So they're blocking both the cyclooxygenase leading to prostaglandins and the lipooxygenase leading to leukotrienes. It's the only drug class that starts at the top, blocking both of these. So even looking at all of this, a lot of people kind of tune out when you see all this pathophysiology. In a way, it's very valuable because it helps to put in place a very good treatment protocol. So let's go back over it. In the early phases, that 1 hour or so time frame, and we've got this cross-binding of the Ig molecules, as was described on the second contact with the allergen, and then a release of heparin, tryptase, kinase, and again, histamine. And Dr. Storms covered this really well. What I want to emphasize, though, is really this area here that comes in with the newly formed mediators. And then over time, the late phase at 4 to 24 hours, you get that resultant chemotaxis and these kind of things that cause a lot of trouble, your mast cells, eosinophils, and basophils. And you can see how they really fill this area here. cytotoxic proteins, cytokines, leukotrienes, prostaglandins, platelet activating factor, all of these inflammatory issues. So you can look at this and say, you know, the early presentation is probably going to be best served with an antihistamine combination like Bepreve. The later phase is probably going to be served better by the steroid class. And that makes a lot of sense when you kind of look at even how this allergy cascade develops. So let's begin with this side here, which is the steroid application. Allergy is actually indicated for temporary relief of signs and symptoms of seasonal allergies. Why is that important? Well, if you look at the newest antihistamine combination agents, which would include Bepreve, which we're talking about today, as well as Lasticaft, as well as Pataday, none of them have an indication for signs. They don't even have redness. None of them could achieve that. They all do have symptoms, though, of itch, and you saw the data on Bepreve being very compelling. In fact, even your most severe itch patients, almost 70%, within 3 minutes went to zero itch. So it is powerful when it comes to the symptoms, but none of those drugs have ever gotten the redness or sign claim. That's why when signs are more prevalent or catching up to symptoms, it makes a lot more sense to utilize a steroid, which actually does affect signs such as redness. So this would be 4 times a day. It's going to be a fairly aggressive dosing, and I think that's very important. The safety profile of this drug certainly allows for that. And yes, like any suspension, the bottle should be shook. And normally about 20 times is what you tell patients in terms of resuspending a steroid. 20 shakes is typically required. So it is contraindicated, of course, as all steroids are in a lot of different areas. And I'm a fairly large steroid prescriber just because of the setting I'm in. I'm in a cornea practice. 80 to 90% of my patients are referred in from colleagues. I don't see any primary care, so I intend to use a lot of steroids. In fact, one of the reps was by my office earlier, late last year, and said I was the #1 prescriber of Lotamax ointment at the time in the country. I thought it was kind of neat. So I don't want to say I don't, because I do prescribe a lot, but I'm very cautious. Even now, almost 20 years of practice, I still don't write any refills for steroids the first time. I want to force the patient to have to come back. Because if it really is working well, and they got 3 refills, that could go a long time before they show up, and I don't want them showing up with pressures of 30, even if it's 3 or 4 months down the road. So I don't even write a refill the first time. I also avoid it in any viral conditions, like HSV that might be present. Any sort of active infectious condition that I don't know what it is, ranging from active bacterial keratitis to fungal to mycobacterium, I don't know what it is stage, but it's an infectious process. It's contraindicated in patients with known hypersensitivity, of course, to any ingredient in it or to steroids. It is associated, you still have the same cautions. You always have to bring a patient back about 3 to 4 weeks out to check for pressure rise. Any change in vision, cataract formation, secondary ocular infections. Now, the nice thing as you get towards Allergy, the safety profile is pretty amazing being an ester steroid. But I think it's important to monitor all these things as well. Yes, sir.
Well, honestly, off the record,
yes.
I know that you have to say these kind of safety warnings, but in your own experience with Allergy, with low-retinol,
yes.
how often do you really get pressure issues with steroids?
It's a great question. The question is, in my own clinical experience, how often have I experienced any sort of significant pressure rise with the loteprednol category, which includes your Lotamax and now Lotamax gel and Alrex? So having been kind of a big believer in this, because I know steroids are the only thing that work for so many patients. I mean, you really have to go that route. I've had a good chance to try this out a few thousand times. And I'll tell you that the incidence in my personal experience is about 1 to 1.5%. So it's not zero. That means an IOP rise that gets them into the mid-20s and higher. Now, that's more Lotamax, where I'm seeing that kind of percentage. And the clinical data here you'll see was actually about 2% for the loteprednol franchise in clinical trials. With Alrex, I rarely see it. Now, I won't say it's zero. I've taken some steroid responders, put them on Alrex to control the inflammation, and the pressure has stayed high. I'll show you some data on this in a minute. It's really pretty impressive because it shows it's pretty comparable to a placebo. So you got I'll show you the data that came through. There's also a study by Ilias on Alrex where patients were followed for 3 years of use. Some patients used it 4 times a day for 3 years, and there was no incidence of IOP rise, no incidence of cataracts, and no secondary infections. So the Ilias study is very interesting. That being said, I still want to see this patient in a 3 to 4 week time frame. I've never seen a cataract develop on any patient I've ever put on loteprednol, so I think that's difficult. It's not impossible. You still can get a shift base, but difficult. But I have seen some IOP rise. But your question's great. The older ketone steroids, if you use them for 1 to 2 months, you typically saw an 8 to 12% significant IOP rise. To go from 1 to 2% is pretty significantly improved. So if you're going to get a steroid response, it's a very good question. When are you going to see it? Typically 3 to 5 weeks on any sort of ketone, sort of ester steroid. In a known steroid responder on the older ketone version, sometimes it can happen within 1 to 2 weeks. And I've even seen some of these newer, really strong steroids develop a steroid response in about 1 or 2 weeks alone. Yes.
You said in the early phase, mast cell stabilizer better, later on, prolonged the
Antihistamine mast cell stabilizer, right.
classical patient pulls up in the morning, the eyelids are all swollen, they're all itchy. I mean, that could have started in the middle of the night, it was okay. The night before, in the morning, it's starting to be a problem. They come in, you've got the itchy and the swollen blades, chemosis. Would you at that point still start with a mast cell, something like a treat, or would you wait for steroids?
This is a great question because, remember I said earlier, a lot of doctors will determine when to use a steroid versus when to use an antihistamine mast cell stabilizer by the amount of time that's passed. And so this question is exactly that. What if, as so many patients do, overnight they had allergens in their hair, they went to sleep, it got on the pillow, they had a significant reaction, they come into the office the next morning. How do you determine time frame in terms of what to use? And it's for that exact reason, that's why I like this question a lot. It's for that exact reason that I don't really go by time frame. I actually go by presentation in my clinic. So if they came in and they said, doc, the main thing that's bothering me is itching. I don't think anything does better than an antihistamine mast cell stabilizer combo. That's really the best thing for itching. Yeah, so the patient comes and say, doc, I've got itching, but my eyelids are swollen and I look terrible and people think I'm drunk. That's more signs. Then I'm going to use a steroid on that patient. I could always go back to the mast cell antihistamine later, but I'm going to start that patient on a steroid. And the question is, would you ever use both? In really severe conditions, I would certainly use both. I've had patients come in and say that, I can't even sleep at night. My allergies are so bad. You've probably seen some degree of that as well. I've got other, issues that have really affected my life. I may often begin them on both. And certainly the non-traditional forms, atopic keratoconjunctivitis, vernal keratoconjunctivitis, those I would often use both as well. And keep in mind, there's probably more vernal out there than you realize. One thing I started learning a few years ago is that if a child comes in, because that's the group that's most commonly affected by vernal, and you look at the limbus and you see any elevation, any eosinophilic elevation, that diagnosis is no longer seasonal allergic conjunctivitis, that's vernal in a child. So, because remember, the two key signs of vernal are cobblestone papillae under the upper eyelid or limbal accumulations. And you don't need 360. Sometimes 1 clock hour is enough to change the diagnosis. In those patients, I would use both agents to begin with. Now, the other question, and we'll get back to the presentation, though, it kind of comes in is, in those severe cases, or we're using both, when do you involve an allergist? And because that's the other part, is maintaining from a systemic component all of that. When do you think we should be sending those over to an allergist to decide? Is it obviously the severe vernals and things, those are pretty typical, but what about the seasonal allergic patient? Is there a time or perennial child with perennial allergies that we may want to consider sending a patient over?
Well, first, get them treated and get them fixed. Then if it's recurrent, like they say, well, every spring, I'm miserable for a month or two, then that's one point at which you might consider. Or if it's more prolonged, let's say they come in, you treat them, and then you get them, let's say they're on Allerex, and you drop back to Bepreve, and then they come in a month later, they say, well, I still need the Bepreve, and then a month later, then if it's a more prolonged season, 3 to 4 months, that's another reason to consider. The other thing to do is ask them if they have nasal symptoms, stuffiness, postnasal drip, itchy, drippy, things like that, sinus headaches. Then that's an indication to get them allergy tested so we can identify what those allergens are, and then if it's something that can be avoided or something they can do differently, that's good. They may also need some other medication, oral, or maybe even a nasal spray.
Excellent. Got a lot of questions for you at the end, too, because that's neat insight. Good. Well, let me go through a little more here, and then we'll come back. And if you have questions, this is excellent. Then we'll open up some time for that even again at the end, where we can kind of ask questions amongst each other too. So if it's used for longer than 10 days, according to what's listed in the insert, then you do want to kind of measure intraocular pressure. And I typically, yes, sure, Bill.
Is that class labeling, or is that specific for Allerx?
It's actually class labeling, which really doesn't make as much sense with Allerx. The question is that class, and that's really the steroid class labeling. Every steroid will have that written in there. And that's a very good question, because clinically, I'm not going to see the patient at 11 days. It just doesn't seem to make sense depending on what I'm using it for, where I'm at. I might give them a little time to check it. Now, if they're really severe, then I will actually see them within 2 weeks. So it kind of follows, but that's class labeling. Yeah, I agree. That's a good point. So the ocular adverse events noted, and I think this is looking at patients treated with loteprednol and tabinate 0.2 to 0.5, which is Allerx to Lotemax. In clinical trials included burning, abnormal vision or blurring, burning on installation, chemosis, discharge, dry eyes, epiphyseal foreign body sensation, itching, injection, and photophobia. And of course, these were between 5 and 15%, but there's a lot that's kind of listed. And again, class labeling was discussed here, as is this one, but I think you do have to watch that. I don't tend to use steroids on top of contact lenses, for example. I'm very cautious in that. I don't tend to use them in the presence of an abrasion. I won't use them when there's an infection. And at the same time, I've probably seen more damage to eyes where colleagues have withheld a steroid when it should have been used. So I'm trying to give you the balance that there are times when you have to go to it. And patients with a lot of signs will do better with a steroid like Allerx for allergies. But there are also cautions that you should do with every steroid. Now, fortunately, this one does have a nicer, safety profile, and we'll touch on that as well. Short course of Allerx provides multi-symptom response. And again, there's no other drug that's currently out of the 3 that are approved, the Pataday, Bepreve, Lasticaft, and then Allerx on the steroid side that has an indication for allergies. None of them have signs except for Allerx, only the steroid. This redness is really critical, and that helps me also to decide my treatment protocol. So for the patient that woke up in the morning, and if they present and said, I'm really bothered by the way I look, that's a steroid treatment. They say, I just can't keep my eyes, it's just this incapacitating itch, it's driving me crazy, that's an antihistamine mast cell Bepreve type patient. So burning, discomfort, foreign body sensation, tearing, itching are all included in terms of the effect of Allerx on allergy sufferers. So let's take a very similar trial comparison. There are 2 sites as well, similar to what Dr. Storms presented in the Bepreve category. In this case, it was a site at Dell Laser Vision Center down in Austin, and then the Shulman Center. And so these patients were given the drug as per the labeling 4 times a day for 42 days. And then the vehicle was given to the randomized other group. So we had 66 patients in the Dell study on drug, 67 on placebo. In the Shulman study, 67 on drug and 68 on placebo. So very nicely balanced out. And then there was 2 things. What happened to redness at day 14? What happened to itching at day 14? A lot of people say, yeah, but this says 42 days. Well, that was the safety part at 42 days, what happened there. So here's what you see. A very quick response. If you look at, first of all, again, this is important because no other drug in this class has got, out of the ones we just described, has a bulbar injection or redness claim. So when did that happen with the steroid? Statistical at 2 hours. So not only does no other drug have it, that was included days and weeks of use. This one has it at 2 hours. So again, it goes back to looking for what you see on your slit lamp and what the patient says to determine the best drug class and how to treat them. Of course, statistical at day 2, 3, 7, 14, every other time frame as well. And then if we look at symptoms, the severity is according to injection. So this is actually changed from baseline, before and after in the one study, the Dell, and then this one's in the Shulman. You see, again, statistical at 2 hours. So amazing how much overlap between the 2 study sites, which really confirms the efficacy of this drug, that both sites had the same results. Now, what about itching? Well, interesting enough, remember I said if itching is the main thing, I prefer the antihistamine mast cell stabilizer. This kind of supports that too. Yes, it controls itching, but statistical was 2 to 3 days, 7 days, 14 days, 7 days, and 14 days. So on the signs with itching, you're going to get the itching controlled with Allerx too, but if that's the immediate chief complaint, I kind of like the Bepreve option for treatment. If it's signs, I really prefer the steroid as we saw in this slide here. So the Dell, this is also quite fascinating. Comes back to your question earlier about safety. So at 45 days, I looked at all these patients and found that in the Dell study, 0 patients had a significant, that's 10 millimeter or more increase in pressure. That means someone who had pressures of 12 went to 22 or above. 0 out of 66 for Alrex, and of course 0 out of 67 for the vehicle. In the Schulman study, they had 1 out of 67 for Alrex, and guess what? 1 out of 68 for the vehicle, meaning identical. Steroid. Same incidence of IOP rise, significant IOP rise as the placebo. I don't think we've seen that in any other steroid to date. So your question was very good. Realistically, this is more what we see in clinic. Fortunately, in this study, it was supported as well. So it covers the early and late phase. I don't want to make it sound like steroids don't work. Back to your question, if I saw a lot of signs, steroids going to control both. But I just want to go on which is the primary in these patients. And it affects early and late. Redness, burning, discomfort, foreign body sensation, tearing, itching. The safety profile was comparable. It was the same number as the vehicle. And the other thing that's really interesting about this drop and why patients find it to be so comfortable is the fact that it has 2 of the FDA monograph components for dry eye treatment, glycerin and povidone, as far as the monograph, not saying in terms of the drug, but for the monograph that's there, which gives it this kind of surface effect and a very comfortable drop. I think that plays a key role with the povidone and glycerin that's in there. And then we discussed the ocular adverse events in the previous slide. Yes, sir. This is great. I love it.
Talk about adverse events.
Yeah.
And I know for sure that nobody has studied this. I'm right on the same page as you. That if you want to be everybody's favorite doctor, you want to do this. Loteprednol is the best thing since the second coming. Do you have any experience yourself in Ohio with triggering the emergence of opportunistic microbes? Let's say HSV1 or something like that. Been stung before, never with loteprednol.
Right.
We all want to give it. We all want to make people happy. Any experience on it?
Yeah, this is a great question because this is part of the section I really didn't cover when I was talking about the steroid, how I am fairly risk averse. And I mentioned to you earlier that I'm cautious if there's an abrasion present, whether it's a ketone steroid or better the ester steroid. Either way, I try to avoid them in the presence of and it's more for Lotemax where it has a broad indication. The Lotemax drops broad indication of using it in the presence of an abrasion. I kind of avoid it. I've had, I think you're 100% right. The majority of the time we've seen a secondary infection used to be with the ketone steroids, but I had one patient who had come off of chemotherapy with really severe dry eyes, and nothing would control it. And I placed her on a steroid, and I got a secondary infection. I got a fungal infection, and it's been 3 months of therapy to try and get it controlled, and her vision's still about 20/70. So it's going to happen, but it's very rare. And of course, that was a very immunocompromised patient with a really bad cornea. But we were at the last stage. There was nothing else we could kind of use to get her functional. That was actually loteprednol. So it has happened, and it can happen. But that being said, how many times have I used loteprednol? Probably, not exaggerating, in the thousands of prescriptions over the years. So the incidence is low, but I don't think anyone is completely immune to it happening. Now, prior to that, we only had ketone steroids. And I would get a fair number, especially in transplant patients and stuff like that, where I get secondary infections. But again, the overall incidence of any secondary infection is probably, I'm going to guess in my clinical experience, extremely low, like maybe 1 in 400 or 500 patients.
Can I qualify that by saying I only want to talk about the polar labeled loteprednol,
Only the
non-penetrating loteprednol,
okay.
in herpetic disease? Let's talk about that.
In its use for herpetic news?
Have you had any experience being burned by having herpes surface while you're doing loteprednol? I haven't, but when herpes disease surfaces, it's just you regret everything you've done.
The question is on herpetic case. Have you ever had a herpetic case? Just go specific to that. And that's probably the better area to focus on because if there is an opportunistic bug, HSV1 is certainly wins the prize for that. Well, have I ever had, well, yes, I have unfortunately done the steroid diagnostic test for herpes in the past, where you accidentally think it's something else and put them on a xylate or something. I will admit I've done that. I used to see it more often in things like Tobradex and that, but here's the interesting thing, is that if you suddenly did make that mistake, which I've done, at least I know of 3 times I've done that, where one looked like a classic staph infiltrate in the periphery, and I went ahead and put them on, I can't remember at the time, it might have been xylate or Tobradex. Maybe it was a long time ago, it was probably Tobradex. It was the last 10 years, it was probably xylate. But nevertheless, I always tell patients when they leave, if you have any increase in redness, pain, or drop in vision, I always say it so often, my staff even say those three, I want to hear from you. And this guy, of course, called the next morning, and he was in increased pain, decreased vision, and increased redness. Of course, I said to him, you only needed one of those three to come back. But he came in, and I looked at him, and sure enough, there's a big dendrite right over the limbus and into the cornea. And I said, well, good news, we know what you got. And I took him off of the medication. I put him on Zergan, if it was today, for sure, 5 times a day till the ulcer goes away, and then 3 times a day after that. I've never had one cause a problem. I think if you put it on something that was a true dendrite, that's when you start to have problems, or something that is really obvious. But if it's not obvious, I've never seen that cause any detrimental damage to date in those. And that's a very, very important question. Good. All right, wonderful. So differentiating the optimal patient, and then we'll take more of these great questions. This is where I think the great value is in questions like this. For patients seeking first-line year-round relief of itching associated allergic conjunctivitis, and I talked about this earlier, long-term, even though there's some Allergy data long-term, the patient with the really severe itching, or even with just itching as their primary complaint, but obviously severe itching data was more compelling with Bepreve than anything I've seen to date. But let's just take the one who comes in with more symptoms and signs. You've got the 2 options. Now, I will tell you, it makes sense to write for the 10 ml for these patients. Many times they'll get one copay, and that's a big bottle, especially now with all the other drops being 2.5 mLs or 3 mLs. That 10 really shocks people. They feel like they get much better value. Alrex also comes in 5 and 10 ml. This would be more for the multi-symptom relief where the signs are obviously present with the symptoms as well. So let me go through a little bit more on kind of asking that. If I've got, Bill, I'm going to ask you this. If we've got a patient in our office who comes in with, obviously we kind of are concerned sometimes in some of our dry eye patients of allergies because antihistamines can dry the eyes out even more. Is there an inhaler or a spray, I should say, that you kind of lean towards that seems to work well in those patients, and does it cause less drying?
Well, the nasal steroids usually are pretty effective for that. Now, you can tell me whether they cause increased IOP and cataracts, but that's rare. Good. Glad to hear it. Because every time, this is an aside, but every time I have a patient who's been on a nasal steroid who ends up being in their 60s and they get their cataract removed, guess what the ophthalmologist tells them? I caused their cataract. So nasal steroids are quite effective, and you've got many of them. Flonase, Nasonex, there's a lot of them. Then there are the nasal antihistamines, and that's Azolastine. Astelin is the brand name, and Patinase is the other nasal antihistamine. Now, they're not quite as potent in my experience as the nasal steroids, but they're not a steroid, so some people don't like the steroids. I'm not sure that anybody's done a really good study on Astelin and Patinase looking at dry eyes. I think they looked at the symptoms. Did your eyes get dry, yes or no? That's not a very good way of assessing that.
Makes sense. I'll answer your question about how often do we see cataracts in those who are on like Flonase or Vanconase or anything like that. Very rare. And truthfully it is. I think that their presence can happen. You can get an IOP rise. You can get a secondary infection on those steroid inhalers and sprays, but it's pretty rare. Now, that being said, when I moved to Kansas City from Indiana, I grew up in Ontario when I was little, so I played a lot of hockey. I was never big to go far, but I was pretty fast, so I got to play a fair level. And I played in Indiana and then went to Kansas City. I was part of a group of players that was in a men's league that all had varsity players, so they were really talented. They're probably better than I remember playing anywhere else, strangely enough, in Kansas City. So, but when you get kind of older and slow, they put you on defense. So I get stuck in the back, and they paired me, not being a big guy, I guess, with the biggest guy on the team. And he was like 6'6", and on skates he looked like he was 7 feet tall. He's more lanky than big, though, but nevertheless, he was pretty good. And then after a year or two, we started not winning anymore, and he was always missing the puck a lot. It'd come to right on his stick. And one of the captains on the team, when we were after a game, said, "Hey, Smitty, we're noticing you're missing the puck. I mean, it's right on your tape many times, and it seems to miss." And he says, Karpecki over there is an eye doctor. And I looked over, and he said, "Yeah, why don't you get him to check your eyes?" And I said, "Sure, Smitty, you want to go after the game? We could take a look." And I took a look at his eyes, and 2 PSC cataracts, good size. And I said, Smitty, have you ever, you're not diabetic or anything, so no. I said, you ever been on steroids? And he said, well, look at me. No, I'm kind of thin. I said, that's true. I don't mean those steroids. I said, ever been on steroids in the eyes, like, Pred Forte at the time, because this was, 12, 15 years ago, or FML or any of those? He said, no, I don't recognize those. And I said, what about inhalers or sprays? He goes, well, yeah, I'm on Flonase. You probably noticed before every game I use it. I said, how long have you been using it? I said, at least 20 years. I said, well, that actually, in his case, did cause it. So he did fine, though. He took cataracts out. He had 20/20 vision, and never made him a better hockey player. I was really kind of disappointed in that. No, he did fine. He was actually a pretty good player. But it's the first case that I was aware of. That being said, I've only seen one other in my entire career, so that's how rare it is. It really is. Yes?
Oh, 10, 20 years.
10, 20 years of use.
I mean, some people.
Yeah, this guy was that, and he couldn't go without it. So the question is, how do you decide to monitor? I don't know that there's guidelines for us monitoring people on steroid inhalers and sprays, and I think my recommendation would be, though, that it probably within the first 3 months to get a baseline. I don't think you're going to respond, but just to know, I think it'd be really important, maybe even in that first month. I know that's not being done, but that's a good idea. And then I would say, every 6 months, the longer you go without responding, the less chance you do. But I would see the patient every 6 months, then definitely yearly. And I think it would be important, even though it's rare, and he didn't have a pressure rise, he just developed PSC cataract. If they were to get one, I think you just want to make sure they're not going years with that. I've never seen a significant IOP rise on it. Maybe some doctors here have, people like Stephen and others, but I think it'd be good to, we don't develop these protocols. I think it'd be a good idea. Stephen, and then David over here. Stephen? I'm going to let you answer. When would you pull the trigger on an oral steroid like a Medrol dose pack?
Well, for eye problems, I wouldn't do that. I refer them to you. But for allergic rhinitis, for instance, we had a bad pollen season this year, and we had in the spring, and we had some fires in Colorado. A lot of people were irritated by the smoke. So we used more Medrol, more prednisone, more Kenalog than we had in previous years. In general, most allergists try to avoid using that, but when you start getting somebody whose allergic rhinitis is complicated by sinusitis and maybe a little bit of asthmatic bronchitis, then you have to do that, pull the trigger, as you said. But it's usually a 5 to 12-day course, hopefully not more than once a year.
And on the ocular side, actually it's going to parallel that very well. I've only ever used it in patients who that their eyelids were so swollen, they've got that little tiny fissure, and you knew it was allergy because it was itching. I've done that in those patients and others that have other signs besides the ocular. And I've done it in a non-responsive kind of condition as well. So either really severe presentation or non-responsive over time. And I do the same thing. I just do the 80 milligram Medrol dose pack, which typically is about 5 or 6 days. I've never had to go to a second. The only contraindication, or not even contraindication, take that back. The only area you got to be a little cautious is in a diabetic at times. It can affect there. But even then, I tell you that we probably underutilize it. So I'm glad you asked that, Stephen. I think there's really a place for them. And in some of these patients, it's the only thing that will eventually resolve those severe allergies. I might try Benadryl first, though, if you're not sure, if you're kind of concerned about an oral steroid. But I think it's a great application.
And you're free. I've heard this with some frequency. They're on it a couple months, and they actually come in saying, it's not just my eye that feels better, around my eye. So you see that periorbital advantage with your free, almost like a minimal sinus benefit. Anybody comment?
Yeah, I'll tell you, I've seen the exact same thing. The question is, what about these non-ophthalmic symptoms, nasal congestion, rhinitis, itchy palate, etc.? In the interesting thing about Bepreve is their secondary endpoint, since you asked the question, and of course that wasn't in the presentation because it's not part of the labeling, but they were kind of smart, and their secondary endpoint was actually non-ophthalmic symptoms, if I'm not mistaken. So that includes nasal congestion, rhinitis, itchy palate, and can't remember the fourth one, but they're exactly what you just described, Stephen. And they statistically met the endpoint for those non-ophthalmic symptoms, meaning the drop in the eye statistically eliminated those symptoms we just described. And I do see that in patients. In fact, that's why I try to avoid the oral antihistamine, because I know a drop like Bepreve is going to eliminate all of those other symptoms in most patients as well. That's very perceptive. It was actually shown in one of the studies. Yes, Sean?
Traditionally, how long do you keep the patient on either Bepreve or Allerex? If it's depending how it's mild or severe, do you normally write it for 10 days and discontinue, or what is your normal protocol?
Yeah, so what's the protocol? We didn't really go through that as much, so I'm glad someone asked the question about that of duration of therapy. So if it's if it's a first-time presentation, it's not a person who says, I suffer from allergies every single year or more going on, like we talked about, seeing an allergist in those areas. So let's take this as out, got something in the eyes, it's been nonstop, incapacitating itch. I'm typically going to put them on something, since itch was the main complaint, I put them on Bepreve, especially the severe forms. I can get a pretty quick response. I always tell patients, I'll often sample it in the office and say that you should get rid of your itching should be gone by the time you get to the desk. And they're always amazed by that. It does happen. Twice a day, I want to see you back in 2 weeks to see if it's better. If it's not better, I want to see you sooner. If it's getting worse, I want to see you sooner. And I want to see you in 2 weeks if it's not better. But it's still good to see them at that point to see where they're at.
And if it is better in 2 weeks, you tell them to discontinue.
So if it's better at 2 weeks, I do tell them that they can discontinue it now. And I always recommend cool compresses if there's a lot of chemosis or edema. And I always recommend an artificial tear to rinse out the allergens. So if they're really good at 2 weeks, I'll tell them one of two things. I still see some signs of papillae, some signs of hyperemia. I'll say, keep using this until the bottle's finished. You've already paid for it. It's handy to have. But if it's truly cleared up, I'll just kind of keep them on the artificial tears, and they can go back to that if they need it. Now, the perennial allergy sufferer is the tougher one. They can go through periods that go up and down. And so I'll often tell them to have it available. Then I'll prescribe the 10 ml, which probably makes sense for most, since many times it's the same price as far as co-pays if they have the insurance. But if not, the 5 ml is kind of good for the first time, 10 for these perennial sufferers. They get to the point where, I hate to say this because it is twice-a-day dosing, but they know when to use it when their eyes are bothered, and they'll do that for a period of time, and then they'll stop, and then they'll use it again. The toughest one is more the Allerex patient, where it's more of the signs, a lot of chemosis continually there in a perennial allergy sufferer. I will start them on 4 times a day, 1 or 2 weeks, and then that's kind of on label. But then I'll take them down to twice a day, monitoring their pressure. And I will do that till they really can get full control, which may be 2 months. And then I like to go to a pulse dosing. Use it for 4 to 7 days when it's really bad.
And if a patient comes in as a possible sign of maybe bacterial, they come with allergic conjunctivitis, but there are those patients that maybe have had blepharitis, you're not sure what component is bacterial. You sometimes put them on a combination steroid antibiotic, or are you always clear whether it's one or the other?
No, and that's a good question, because I'm not always clear, because there's a lot of confusion. Even when you see a patient, there is comorbidity. So the question's great. What about patient who, you're looking at it and there could be comorbidities, both allergic and maybe even some blepharitis and bacterial issues? How do you decide when to do the combination agent, which still has the loteprednol in it, for example? I really base more of it on the cornea. In other words, if the cornea is showing any signs of compromise, then I want that antibiotic there to be safe. It kind of keeps me feeling a little more confident. But if the cornea is not showing any stainings, completely intact, there's no infiltrates or anything at all going on, perfectly clear, everything's external, many times I'll just go with the steroid, which then helps with the inflammation in other areas like the eyelids. Yes, here and then there, Rob. Yeah, so what if we had the patient that, remember I said if the signs were really significant for the patient, I tend to go with the steroid, especially if it's after a few days of allergies, or if the symptoms were really all they're complaining about, I do the combination. What about the person who's got them both on presentation? Severity dictates that. I mean, if it's really severe, every now and then you'll see this patient has got so much chemosis, their conjunctiva's almost hanging out there, they're really, I think you probably need both, because the itching is probably playing a role. Maybe they're even rubbing their eye. That's why it's so bad. But if I've got mild case of both, I'll kind of try to tease out which is worse. And if they're very close, I'll just do the steroid in those patients and save the antihistamine till later. So if it's a really severe form, yeah, I've used both. I've had patients come to me and say, I can't go to work. My allergies are so bad in my eyes, I can't get on the computer, I can't work. And part of it's from the chemosis, part of it's from the itching. Though it's severe enough, in my opinion, to use both as well.
Do you have a steroid responder? Do you tend to change medications, or do you do pressure-lowering drugs?
Yeah, this is great. These are awesome questions. I gave a number of lectures today. I didn't get as many good questions as tonight. This is great. So how do you decide on a steroid responder, whether you change the steroid, or whether you add in a glaucoma medication? So two things really dictate that answer. Number one, what am I treating? So for example, let's take a case of iritis. Obviously, uveitis can be very damaging. You can get synechiae, you get all kinds of problems. They still got grade 2, 3 cell. Their pressures are 36. I can't stop the steroid. If I do, I'm going to get synechiae, I'm going to get permanent damage, I'm going to have cells and flares go crazy. I got to add a glaucoma medication. So one of the indicators is what you're treating. If you're treating a severe inflammatory condition, you're going to have to add a combination. I like Combigan. I think if they don't have breathing problems, Combigan seems to really lower pressures for a lot of patients who are steroid responders, and I just keep them on the same steroid. If, however, I'm dealing with, and if it still stays high, then I would absolutely consider an ester steroid. So it depends. So in the severe cases, I may well switch. Now, if say the person had an iritis, the other factors at the time. Say they've had an iritis and I've got them on, I don't know, maybe it was so bad that I started them on a really potent, like a Durezol or something really strong, and they're already past 2 weeks, I'll switch them over to Lotemax right away. Lotemax is very powerful. In fact, I don't know how it got a reputation being soft. There's a study out of Japan that showed it was equivalent to Pred Forte, branded. So, I mean, it's a good drug. So I'm going to feel confident to switch that patient and see what happens. If it's a case of a milder condition, ocular surface kind of issues, that sort of thing, then yeah, I'm probably going to start them on a loteprednol. So if the pressure is really high, which sometimes happens, then I'll just taper them down a little quicker. So really almost 3 answers. So severe type of disease and duration of the disease dictate whether to add in. So really the most severe, debilitating, dangerous condition, I can only add a glaucoma medication. Late in the stage, I can switch to loteprednol, and in milder condition, loteprednol to removal. Very good. I'll do first, and then I'll come back over here. I think you did have your hand up early, too. Let me get your question. Let me come right back to you. Oh, awesome question. If someone's a known steroid responder to a ketone steroid, are they likely then to also be a steroid responder to an ester steroid like the loteprednol family? And Jimmy Bartlett actually studied that. He took known steroid responders, 100% of them had significant IOP rise. He switched them over to ester steroids. 18% remain high steroid responders. So that's almost 1 out of 5 will remain. All the others came down dramatically. So it means there's a good percentage that you can do that, as per your question as well, and they do just fine. But there's 1 out of 5 that stayed 35 or whatever it was. So. Oh, what about the use of NSAIDs is the question for treating allergies. Do you ever use any of those at all? I think it's kind of Beprive. I'm the same thing. I tend to just use Beprive, and I tend to just use steroids. And the reason being, this is my logic, that doesn't mean they don't have a role. I'm seeing some of these newer ones as considered off-label, but they seem to work so well that many patients do great with them. But that being said, if I take a look at, let's take Beprive, antihistamine mast cell stabilizer, last cap, Bataday, any of the ones in that category. I no longer use mast cell stabilizers alone, like an Alamide or an Alic, whatever those were, because you've got both in the first drug. And same thing I find on the steroids. NSAIDs block the cyclooxygenase pathway. Steroids block cyclooxygenase and lipooxygenase pathway. I get much more effect up here, so I've kind of stopped using those as well. But if I had a steroid responder, a person who long-term needed something like the cases you described, that may be a good application there. Yes, Rob? Time for one more question, and I'll stay up here for others as well.
Just interestingly, loteprednol, when I first heard it come out, it was, like I joked earlier, the second coming, because it has a polar site. And loteprednol is designed to stop before it gets too deep into the tissue. It doesn't have penetration abilities. It's labeled or tagged to stop in the epithelium, which is
Okay.
why we use it for surface disorders. As a result, I usually like to check the integrity, the ocular surface disease status of a lot of our patients, because the ones that tend to have these either pressure reactions or other types of side effects don't have the kind of surface integrity that they should. So that's one kind of consideration.
It's a great consideration.
The other thing is, for the benefit of those who really don't deal with a lot of hot eyes, or maybe new eye doctors out there, we all develop this intuition. When you walk into a room, you guys, you walk into a room and you look at things, and I know for a fact you can decide within 30 seconds what you're going to prescribe already.
Mm-hmm.
What are the things you see that make you make a decision between, let's say, Reprieve and a topical antihistamine and a topical steroid? What do you see that kind of...
Yeah, that's a great question. Everybody hear that? I think Sam covered it well. I agree with you. I think most of us are making our decision in that first 30 seconds. I base it on more chemosis. I base it on the conj. I think if I had to give you a simple answer, I base it on the conj. And yes, if there's lid edema, I'm going to kind of look at that too. But if I've got redness and chemosis, those antihistamine combinations, even as good as the Reprieves, don't control that as well for me, and it takes too long to do it. So I guess lid edema would be another application, but the conjunctiva really will give me that answer more than anything, because if it's chemotic and if it's highly, a lot of hyperemia, a steroid's going to be my much better choice. And patients are going to respond that way too. They can come back and say, wow, this really made a difference there. If it's itching, it's the opposite. Mm-hmm. Oh, have I ever used lissamine green or a conj dye to help in the diagnosis? There is some reports of utilizing it. I mean, I know they stain areas of breakdown, areas of devitalized cells, dying cells, areas of lack of mucin coverage. So there is probably some logic. If you've got a highly swollen conjunctiva, you probably have some cells that are dying. So there probably is an advantage. Now, where you're going to get confused is if someone has dry eye and the mucin's not protecting it, that'll all stain too. And that really doesn't tell you as much about the allergies. But I don't, but it's a good thought, and there is logic to it in these patients because those cells are prone to damage when you get a high level of inflammation, and maybe that helps dictate you going towards a steroid than not. But I'd have to see a good study on it. But it's a great idea. Probably something there. Yeah, I should. I love it. Can I get this last question, and we'll call it a night? Yes. Oh, yes, okay. Yeah, this one might be a good one for you, actually, as well. What happens right now, I see this a lot, too, where the pharmacy calls back and says, sorry, insurance isn't going to cover some of these. And let's say, I know you have the $50 coupon and all of that, which really helps offset it. But talk a little bit about coverage and about other options. Then I'll talk about kind of because I have had some patients where I've had to go to the over-the-counter AOAs. And even though ketotifen probably isn't as comfortable or as powerful as the Reprieves and other of these branded drugs, it works, and it's an option, and it's inexpensive. And I tell you, if they can't afford Reprieve, for example, they may not use anything. So at least that's something they can use. Now, what I've really found fascinating is when I can't get Reprieve covered or Pataday or Elasticaf, you know what always seems to get coverage? Alrex. So I've been going to that a few times. Does that seem strange to you? Here.
No, so... managed care-wise, the main players in this space are Reprieve, Pataday, Patanol, Elasticaf, and Alrex. A lot of managed care organizations now in the topical ophthalmic space are playing the game that they played in the systemic antihistamine space, where once Claritin went OTC, the coverage of prescriptions within that same class was significantly less than what it was previously. So as the Elestats and Optivars started to go more generic, managed care organizations started pressuring manufacturers much more so in terms of managed care coverage for a class that has gone generic, and you have the ketotifens OTC. As a whole, though, you're looking at one of the branded drugs in the space being covered 80 to 90% of the plans nationally. And that varies from geography to geography, state to state, regional plans impacting certain practices much more so than others. But from a Reprieve perspective, you have formulary coverage, 85% nationally for commercial, significant numbers for Medicare. But Aurex does in the class, or in the allergy space, Aurex has the broadest managed care coverage across both commercial and Med D, primarily because it's the one and only non-antihistamine mast cell stabilizer that has that indication for seasonal allergic conjunctivitis. And what manufacturers are doing are really playing the game of coming with copay assistance type programs. It benefits us and it benefits the patient more so than us just lowering the cost of the drug. If we took a drug that we price at $60 now and lower that to $30, the markups are still going to be the same, and at the pharmacy level, they'll still mark it up, and it'll cost the patient $120 still, and their profit margin will be significantly higher. So what we do then is incorporate copay reduction type programs where we still sell it for the same to the wholesalers who sell it to the pharmacists, and then the patient pays less based on the rebate programs we have in place. It's very interesting as to how product gets from manufacturer to patient, and we really dictate the price the patient pays minimally. It's wholesaler, pharmacy, managed care organizations taking their cut. So unfortunately, we do have to cut this short. The hotel will bill us significantly more if we keep on going. This was fantastic discussion. We could probably stay here for another 2 or 3 hours and pick these two great thought leaders' minds. Please feel free to follow up. If you have any additional questions, reach out. We can get you in touch with either of them. Really appreciate you taking time out of many options you had this evening. Enjoy the rest of the evening. It's only 10 to 8. And safe travels home to wherever you're heading after the conference ends. Thank you very much.